Welcome back, everyone, to the Infection Prevention and Transition of Care series podcast focusing on catheter care in hemodialysis. Today, we have a very special guest, Dr. Aisha Shaikh from University of Pennsylvania. Dr. Shaikh is an associate professor of clinical medicine and serves as the director of onconephrology at University of Pennsylvania. Her clinical work focuses on one of the most challenging aspects of our field, helping patients navigate through kidney complications that arise during cancer treatments like chemotherapy, immunotherapy, and even CAR T cell therapy. She trained in internal medicine at University of Texas Medical Branch and completed her fellowship at Mayo Clinic. Along the way, she developed a reputation not only as a leader in onconephrology, but as a strong voice in interventional nephrology training and workforce development. In fact, through her leadership with the American Society of Diagnostic and Interventional Nephrology, she helped build a comprehensive national directory of training sites for future nephrologists interested in procedures and dialysis access. She is deeply involved in the broader nephrology community through the American Society of Nephrology, National Kidney Foundation, and regular contributions to research and education on topics like glomerular disease, CAR T-associated AKI, and innovative approaches to dialysis access. She's also currently the member of the American Society of Nephrology's Transforming Dialysis Access Together Education Working Group. So today we are especially excited to talk to her about best practices, new innovations, and strategies nephrologists can use to reduce infections and improve outcomes amongst hemodialysis patients. Thank you so much for making time, Dr. Shaikh, for this podcast.
Thank you, Dr. Chopra, for such a kind introduction, and to you and to the ASN team for inviting me to be part of this podcast.
Well, we're very lucky to have you join us and tell us about, infection prevention that happens in a busy dialysis unit. I guess we'll just dive into the questions. And what, according to you, are some subtle technique errors that you've seen that could make a big difference in reducing the infection risk amongst dialysis patients?
So, it's interesting that we sometimes think of big things that result in bad things, right? Big things meaning major break in sterility protocol that then leads to an awful catheter-related bacterial infection. But I think what is important for all of us that go to dialysis units, that things are pretty busy there, and staff are just rushing from one patient to the other, which is not an unusual sight. And what I have noticed and what has been repeatedly observed in this scenario is even subtle breaks in sterility, hand hygiene, hand washing, simple aseptic techniques, wearing of mask by the staff member as well as by the patient when the catheter is being connected and disconnected. All these simple things and breaks in these simple sterility measures can then sort of translate into a bad catheter-related bloodstream infection. So if you're looking for like a big red flag, these are usually, they don't appear to be red flags. These are subtle errors, subtle breaks in sterility that result in bad outcomes. So I think it's important to realize that yes, things are busy in the dialysis unit, but it is incredibly important to do basic stuff because basic stuff leads to prevention of catheter-related bloodstream infection, which is an awful complication to have.
I so totally agree. And one of our previous podcasts with Dr. Kleiger talked about human factors, engineering, where multitasking is the norm, is what Dr. Kleiger said in a hemodialysis unit. And the nurse and the tech are looking at alarms and, trying to connect and disconnect another patient. So his work about human factor engineering was trying to address these breaks in sterility that you mentioned. And it's one of our previous episodes, and I found his work extremely fascinating on human factor engineering. Thanks for bringing that up. Are there any written protocols that are there in your hemodialysis units that have tried to address these breaks in sterilities?
Yes, and you can write as much as you want, but practice, practice, practice is the most important key, and training, training, training is highly important. So I think every dialysis unit should have a written protocol, and it should be looked at. If you find gaps in it, it should be revised. But yes, a written protocol is an absolute must, and every dialysis staff member should have easy access to that written protocol. If you're making any changes to it as a medical director or as a facility administrator, it's very, very important to make sure that your staff is aware of those changes that you are making in that written protocol. But I think anything written is meaningless unless it translates into training and practice. And so, as a medical director of dialysis units, for us, it was training and training of new staff members in dialysis units. The turnover of staff is very high, so it's incredibly critical to train the staff. And, you have to monitor them and make sure that the so-called training is effective and is translating into adequate sort of practice patterns. So in our case, we would even subtle, simple things. You have to wash your hands. You have to wear gloves. You cannot let the catheter cap drop to the floor, pick it up and put it back in the. And again, these are subtle breaks in technique and these are human factors, but this happens and it may be non-observed by most people, but these are very, very critical. And as I said, wearing of the mask, simple stuff can prevent bad things. So not only should you have a written protocol, you should have a training protocol observing the staff members and ensuring that any new staff member is not only trained but also sort of certified that now they are clear to access patients' catheters. So yes, we had a fairly sort of rigorous protocol in our dialysis unit back in the VA, and that's partly because we had a very high catheter population and our bacteremia rates were high. So we went back to the basics and we implemented these strategies, and not surprisingly, the catheter-related bacteremia infection rates did decline over time. So simple things translate into big benefits.
No, thanks for sharing that. And, we involve our patients in our hand hygiene audits as a form of patient engagement. So they feel like they're part of the team.
Mhm.
And you bring up an important point that having the protocols and audits and retraining is extremely important to reduce catheter-related complications, especially infection. And catheter is something that is unavoidable, right? It is part of the hemodialysis access, even though we would prefer that people have fistulas or AV graft. And KDIGO, vascular access guidelines, when they had come out in 2019, what were the main recommendations with regards to catheter care that pertain to infection prevention at that time?
So those guidelines were very well written. They're very extensive. I highly recommend the listeners to go back to it if they have questions. But those were about 7 years ago. So those guidelines were published in 2019. And typically, these guidelines come out every 5 to 10 years. So it's not unusual for new data to come out. So I'll go back to what in 2019 KDOGI recommended, but then the reader should be aware that new stuff comes out and that may not still hold true in terms of guidelines that were put out in 2019. But I think catheter care, as I've said, they also emphasize basic stuff, which I'm not going to repeat. But I think your question is more specific. What were the preventive strategies that KDOGI recommended? And when we talk about preventive strategies, of course, you want to make sure the hub is clean. Chlorhexidine based disinfectant is recommended unless the patient has an obvious contraindication to its use. The hand hygiene, masking, of course, goes along with it. But then they were very specific about making recommendations about three basic locking solutions. So if you talk about antibiotic locking solution versus antimicrobial locking solution versus a clot buster or TPA locking solution. So what's important to note is at that time when the guidelines came out, the recommendation was use these in scenarios if you have a patient with high bacteria, a high risk of bacterial infection or bacteremia. Use it if you have a facility or a dialysis unit with a high catheter-related bloodstream infection rate, which usually the sort of benchmark is more than 3.5 cases per thousand catheter days. So you can then pick and choose of one of these three strategies. Now, again, 2019, we did not have the latest data on antimicrobial locking solutions, so they couldn't come out and say we recommend prophylactic use of antimicrobial lock solutions. So basically, just to highlight, antibiotic lock solutions, of course, carry the risk of antibiotic resistance. You can consider it in patients who are at high risk for infection, who have, who are going to be dependent on a catheter for long term or immunocompromised. And you can strategically use it, understanding that there's a risk of antibiotic resistance in that situation. The antimicrobial lock solutions, they cannot recommend any locking solution over another compared to heparin versus citrate because there's been no difference between the two. But really, the curiosity was more about solutions that have pterolidine, like antimicrobial. And we'll highlight that a little bit later in our conversation today. But I want to emphasize that in 2019, because we didn't have the data, KDIGO did not come out in support of routine prophylactic use of antimicrobial solutions. But even at that time, they suggested that you could consider its use in people with recurrent bacterial infections, or if your facility tends to have a higher rate of infection. The TPA story is very interesting that, we usually use it for catheter thrombosis, which unfortunately is a common problem in catheters. But we know from a landmark study in many years ago in New England Journal of Medicine, where it also showed that using of TPA lowered risk of bacterial infections or bacteremia. So again, KDIGO was like, you can consider its use based on the patient risk factors and your facility situation and so on. So 2019, they did not come out in support of any of these three for prophylactic use, but that has changed since then.
So since then, what are the gaps in evidence and what practice patterns have changed?
So I would say the gaps, if I were to talk about gap, I would say the gap is that we still see catheter-related bloodstream infection. That's a gap, right? I mean, that's something, that hole we want to fill. We want to see zero bloodstream infections. So the gap is there, but we have more tools now compared to what we did 6 years ago on how to combat this problem of catheter-related bloodstream infection. So at that time, we were using one strategy, which was a chlorhexidine catheter cap. The brand name is ClearGuard, which a bunch of us were using at that time, and KDIGO came in support of it. But now, since then, we have a new sort of approved antimicrobial lock solution, which is a combination of pterolidine plus heparin. And this really came out after a study result that was published in CJSON in 2023. And we were at the VA part of that multi-center study where we had about, in our center, we had about 20, 30 patients that were enrolled. But overall, the study had about 800 patients that were compared to heparin-only lock solution versus, of course, the study drug, which was a combination of pterolidine and heparin. And what was interesting is that the follow-up was not very long. It was about 200 days, so it's clearly less than 1 year. And in that time, there was approximately 70% lower risk of catheter-related bloodstream infection in the pterolidine/heparin group compared to heparin alone group. And that is what led to the FDA approving this lock solution for prevention of catheter-related bacteremia. So this is something new since the 2019 KDIGO guidelines came out, and hence this is different from the guidelines because now we have new data to support prophylactic use of this particular antimicrobial lock solution.
Thanks for shining some light into that. Just a follow-up question on the Lockett study. Did it also show benefit in the well-performing centers with not the ones with just the high catheter bloodstream related rate?
Yeah, so overall, the bacteremia rates were very low. So if you look at the bacteremia rate in the taurolidine plus heparin, it was about 2% versus heparin only was 8%. So these are low rates of infection overall. But if you look at the subgroup analysis of the benefit versus no benefit, the benefit was across the board in most age groups. I mean, the location of the catheter was tricky, because there weren't that many bacteremia events. So I would leave that one out. But overall, I would say it was a pretty impressive spread. Um, but I think this is an important point you raise, that what is the benefit of these drug or this microbial solution rather in a facility that has very, very low rates of catheter-related bloodstream infection? And I think that is something that is tricky to answer, because if your protocols are very good in terms of aseptic techniques, you may not have that many catheter-based patients in your dialysis unit, or you're already using another prophylactic strategy, such as these chlorhexidine coated catheter caps called ClearGuard. You may say, I don't want to use this lock solution because it may not work for me. There's no reason for me to change my protocol, pay money, cost is prohibitive. So yes, it may not be across the board a beneficial thing, but I think this lock solution is another sort of ammunition that we have now that we can use to prevent infections in our catheter-dependent dialysis patients.
Well, thanks for that. And so it's possible that this could be a new default lock solution. And do you think it will become mainstream in catheter protocols?
So I think that's a little tricky and difficult to answer, and just kind of moving along what I said a few minutes earlier. So I think two factors need to be taken into account: your own facility, your patient population, and then the cost. And then what are your current rates of catheter-related bloodstream infection? Now, even in the United States, the cost may vary from location, from what setting you're practicing. So, for example, when I was at the VA, I realized at that time the cost of drugs can be very different in the VA setting versus the non-VA setting. So, what might suit your center in a certain setting may be completely different than someone else practicing even a few miles away from you. So I think when we say whether this will become mainstream or not will depend on several things, like where you are now in terms of your practice, in terms of the catheter related bacteremia rates, what your patient population looks like, what is your resource sort of strategy in terms of cost effectiveness. I will say that, in the hospital setting, certain things are easier to use versus non-hospital settings. So where I am at Penn, we will be using taurolidine in our inpatient setting, but in our outpatient setting, some units have ClearGuard and some don't, because depends on which sort of umbrella, which dialysis chain the unit belongs to. So within one academic setting, I have seen variations of practice, but the bottom line is that we do have strategies, to prevent infections, and what works for your center may be different than what works for another center. And I will emphasize that there's no head-to-head comparison between, let's say, ClearGuard catheter cap, which is a chlorhexidine based catheter cap, versus, let's say, taurolidine based antimicrobial solution. One thing I will add, that the two cannot be used together, because in the Lockett 100 study, the study we talked about a few minutes ago, which was published in CJASN in 2023, the taurolidine-based solution, locking solution, none of the patients in either control group or treatment group were on ClearGuard catheters, caps. So bottom line is that we don't have safety or efficacy data on combining the two. I doubt any center would have the money to do both anyway. But point is that, there is no data on how these two together work. So you can certainly use other solutions like heparin, citrate, saline with ClearGuard catheter caps, but not taurolidine-based locking solution.
Thanks for sharing that. And in the cluster randomized trial, which was the chlorhexidine coated catheter caps, was it predominantly in the outpatient setting, or they had also looked at inpatient outcomes?
So my understanding is that that was one of the huge dialysis chains in the United States. It was predominantly outpatient, and it had 2,400 patients. And among the 2,400 patients, they compared the ClearGuard chlorhexidine cap, which is ClearGuard, compared to standard dialysis catheter cap. And in the ClearGuard group, there was about 56% lower rate of catheter related bloodstream infection. So just to give you an example, at the VA where I practiced, in our dialysis unit, we had inpatients and outpatients coming there because that's how most VA centers are designed. So technically, we were using ClearGuard in both inpatient and outpatient setting. So that being said, most of these patients were predominantly in the outpatient setting. There are some centers that do it inpatient, but I would say this is a data mainly from the outpatient centers, just like the Lockett study, which was predominantly, of course, in the outpatient center, although that was also a multi-center study, just like the ClearGuard catheter study.
Yeah, and we try to look into the inpatient feasibility of these chlorhexidine catheter caps. And what we learned is that it has to be changed every 3 days,
Mm.
which in an outpatient it is easy to do. And in an inpatient, I have to now train my nurses to do that. So that was something that we learned, which was, I guess, a clinical pearl
Hmm.
that we could extrapolate from the data. And so anybody listening out there, read through the catheter care and like Dr. Sheikh said, there is a lot of gaps and unknowns about cost effectiveness, combining therapies, and this could be areas of future research.
That's a great point, and I think a lot of these patients, when they come into the hospital for whatever reason, just automatically get switched to a regular cap, or catheter cap. And we don't know the implication of it, when you switch this around and then they go back to their unit 4 days later and then they have a bacteremia. And is that a break or a fault or a lack of efficacy of a ClearGuard based chlorhexidine coated catheter cap versus just not using it for a little time? Plus, inpatient hospitalization, a different staff is accessing the catheter. A lot of factors potentially could play in, but you're absolutely right. And this is also true for the terolidine-based lock solution. They could be on it in the outpatient setting, and when they come in, they become inpatient for whatever reason, the facility may not even have it. So lots of times there's a lot of back and forth with our dialysis patients, both inpatient, outpatient, and also when they travel to other dialysis centers. They have a life. They could be traveling to another city, and for a week or two, they may have a completely different dialysis catheter care compared to what they were getting in their home unit.
Let's shift gears. And what is your understanding of the fibrin sheath formation within the catheters? And could you help us decide between tissue plasminogen activator versus heparin for lock therapy?
So I would say that when I practice interventional nephrology, the fibrin sheath was a bane of our existence. It is a nuisance. It is there, and it is very hard sometimes to get rid of. And just to emphasize that most catheters will have a fibrin sheath that's just, it's a foreign body, and fibrin will form around it. But the nuisance was not just because it obstructs the flow of the catheter, which we all know, makes perfect sense. You have a catheter, there's fibrin sheath inside, the lumen will get narrower and the flow will be inadequate. That translates into inadequate dialysis, poor clearances, machine beeping, which is a nuisance for the staff and for the patient. So those are the most common reasons why we would have patients sent to our access center to have catheter exchange or a new catheter placed. But that is not the reason we are bringing this up. The reason is it's very interesting because fibrin sheath, which is essentially intraluminal thrombosis, is a harbor for the bacterial biofilm. So, in other words, bacteria are sort of thriving in that fibrin sheath, and they are not just, they're waiting to just enter the bloodstream at any point. And because that fibrin sheath is present in all catheters, whether it's causing problem or not from a functional standpoint, it can harbor bacteria, which can be a source of bacteremia. And I tell this to my fellows. This is one of the reasons you cannot treat a bacteremia just with IV antibiotics, because the penetrance of the IV antibiotics into the biofilm surrounding the intraluminal part of the catheter is not going to be good. So you have a constant source of bacteria present inside the lumen of the catheter. Hence, systemic antibiotics are not reaching the site. And this is the reason you either treat bacteremia related to a catheter with systemic antibiotics plus catheter removal plus catheter exchange, or in some scenarios, an antimicrobial lock solution to target the bacteria that are inside that fibrin sheath, aka the biofilm. So I think what's really interesting about the biofilm, or rather the fibrin sheath, is it's a problem for blood flow of the through the catheter, but it is also a huge risk factor for infections or bacteremia. And I think you and I have offline discussed how interesting the findings of a study were, which is the study that we kind of alluded to a little while ago in New England Journal of Medicine, published in 2011. So gosh, it's been almost 15 or some years now. And I think that is an interesting study. And just to remind our audience, in that study, they used TPA, recombinant TPA, in the middle of the week. So, patients are dialyzing 3 times a week. So, for example, Monday, Wednesday, Friday patients would get a heparin lock on Monday and Friday, but midweek on Wednesday would get a TPA lock. Similarly, the Tuesday, Thursday, Saturday patients will get heparin lock on Tuesday and Saturday, but Thursday they would get the TPA lock. So, of course, it showed that the risk of catheter thrombosis was 2 times lower with TPA versus heparin 3 times a week versus TPA once a week. But what was truly interesting about that study was the rate of bacteremia was 3 times higher in the heparin only group compared to the midweek TPA group. And this kind of just sort of solidifies what we have been discussing, how that biofilm that sits around the fibrin sheath gets busted essentially with TPA. Hence, you also lower the bacteremia rate by also using TPA, in addition to, of course, improving catheter flow rate. So I think fibrin sheath is sort of a niche sort of location for the biofilm to reside and the bacteria to thrive. So it's a nuisance, not just for an interventional nephrologist, as I said earlier, but also for the nephrologists who want to prevent bacteremia in their dialysis patients.
All the fellows out there bust the biofilm.
Totally, totally. That's the goal.
So, Aisha, if you were designing a dialysis unit protocol today from scratch, what combination of technique training, lock solution, and capped technology would you choose and why?
So I would say, I think first thing is catheter prevention. And I think this sounds like a repetitive theme, but I think, yes, some of our patients will always be dependent on catheters, but we should really make every effort possible to prevent catheters in our patients as much as possible, understanding that there will be a group of patients that have no other choice but to be on a catheter for a variety of reasons. But if I were to, and we kind of did this because in the VA population, we had a lot of vascular disease and they just had a lot of failed AV accesses, and we just had no choice but to have patients on catheters. And in that scenario, I would say like infection prevention in dialysis unit begins with meticulous aseptic techniques. I think we can use fancy, expensive tools, but those are not as effective if you're not practicing basic aseptic techniques. As I said, hand hygiene, you know, proper disinfection of the hub, proper connection disconnection protocols, wearing of the mask both by the staff as well as by the patient. These would be my basic sort of starting points. And then, of course, making sure that the protocol is available to staff, they are adequately trained, and then signed off on by whoever is training them. Don't assume people know what they're doing and that they are following instructions. And then I think the question is, I will look at my facility's infection rate. I will look at individual patients. If I have one patient who has had 3 bacteremia episodes in a short span of time, or even 2, I may think of a more individualized therapy protocol for that particular patient, whether it's antimicrobial lock solution, whether it's ClearGuard catheter, and in some cases, even an antibiotic lock solution. It depends on the patient and what are we dealing with. And at the end of the day, it all comes down to money and cost. And I think you have to pick which strategy is most cost effective for your dialysis unit. As I said, within one academic center, we have different strategies, but the goal is ultimately prevention of infection. And bacteremia related to catheters is a very bad problem to have. So I think we've talked a lot about cost, but I think we should not forget context that bacteremia is associated with very high cost, both from a money perspective, it leads to hospitalizations, but also from a morbidity, mortality standpoint, it can lead to metastatic infections, infective endocarditis, osteomyelitis, and patients can die. So, cost of the preventive strategy has to be weighed against these dire outcomes and cannot be ignored. So I think at the end of the day, it is a basic stuff plus added sort of things that you can add to your protocol and your practice, depending on which one is most cost effective and what your dialysis population in your dialysis unit looks like.
That's great. I like the individualized approach by keeping the patient in mind. And if you could give one take-home message, Aisha, to the dialysis staff, fellows, technicians, patients, and our audience listening about catheter care prevention, what would it be?
I think goes without saying the best strategy to avoid catheter-related bacteremia is to avoid catheters, but that was, of course, a little tongue-in-cheek. I would say consistent execution of the most basic aseptic techniques remains the single most effective measure to avoid catheter-related bloodstream infection. So if you were expecting me to say it's that X $1,000 worth of strategy, no, just stick. You can use all those, but if there are breaks in sterility with basic hand hygiene, masking, disinfection, access to catheter during connection, disconnection, none of those expensive measures will be effective in preventing catheter-related bloodstream infection. So to prevent that, you have to try to avoid catheters, but if it's unavoidable, then stick to the basics, train your staff, and then move on to more sort of individualized protocols or approaches depending on your dialysis unit and your patient population and what resources you have available to you.
Well said. Prevention is the best cure. And thank you so much, Dr. Shaikh, for walking us through best practices, innovations, and strategies to reduce infection. And it was nice chatting with you on this podcast and look forward to some more.
Thank you. And Tushar, thanks for the invitation. Thanks for organizing this, and also to the ASN staff who facilitated this podcast. So much appreciated. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional If you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.